Good morning, everybody sitting in the studios, sitting in our regional centers and at other various receiving in centers. Myself, Professor S.B. Arora, Director, School of Health Sciences, and I will be anchoring this particular session. Friend, I, on the behalf of Vice Chancellor of Indira Gandhi National Open University, on my own behalf and the faculty of School of Health Sciences, and President of National Board of Examination, Vice Presidents of National Board of Examinations, and the executive body, and on behalf of Executive Director of National Board of Examination, welcome you all to this historic moment in the field of medical education, as today we are entering into the new technology of teaching in the medical education. We will be having 2 hours session, interactive teleconferencing session, live session. This is being live telecast from the studios of IGNOU, and we'll be having sessions, 2 sessions of 1 hour each, and we'll be talking in this session about how to go about clinical examination. Friend, all of you will agree with me that a good clinical examination, if done properly, is solving half of the problems, and it ultimately leads to the good management of the patients and thereby increase quality of the medical care. And so let me give you brief about this collaboration. This, you see, IGNOU and National Board of Examination has entered into a memorandum of collaboration for providing continuing medical education programs to the medical students of National Board of Examinations, and for that matter any students, any medical students who is pursuing medical education, postgraduate medical education or otherwise also. With this idea, the School of Health Sciences and IGNOU, School of Health Sciences, IGNOU and National Board of Examination entered into a collaboration for providing opportunities for our medical fraternity in the area of continuing medical education through this interactive mode. I think this is an historic milestone in the history of medical education, and without wasting any further time, I will just introduce to the dignitaries sitting on the dais. To my right is Professor A.K. Sood, Executive Director, National Board of Examination. He has been instrumental in organizing this interactive teleconferencing session. To his right is Dr. S. Bhardwaj, who is the Vice President of National Board of Examination. And she has been, right from the day we signed our MOU, she has been very proactive and dynamic in carrying further away the activities of in this direction of continuing medical education. To her right is Dr. Rajesh Khanduri, who is Dr. Pans
Vice President.
To her right is Dr. John Punst. To her right is Dr. K.M. Shamprasad, the Vice President of National Board of Examination. I'm sorry, there was some mistake in writing. So Dr. Shamprasad, sorry for that. Dr. Shamprasad, the Vice President of National Board of Examination, and I think he was also there when we signed our MOU, and the further activities of when you visited our EMPC center, and you were quite instrumental in bringing these activities to this date. Then we have got Dr. Prakash Khanduri, who is the senior consultant in St. Stephen Hospital, and he will be your expert for this particular first session which we are going to have. Then to his right is we have got Professor Arun Kakkar, who is the professor of surgery in the Maulana Azad Medical College, and he will be also your resource person in this teleconferencing session of the first hour. And then we have got to our extreme right, we have got Dr. John Punus, who is senior consultant in medicine at St. Stephen Hospital, and he will be dealing in the second session which we will be having after break. The friends, the schedule is like that. We will be having this first session for 1 hour, then we will be having a break for half an hour, and then we will be assembling again for the second session. So without wasting any further time, now I will request Professor, I will request Dr. S. Bhardwaj, the Vice President of National Board of Examinations, to tell us what are the objectives of National Board of Examination. Madam, please.
Thank you. The main objective of National Board of Examinations is to conduct postgraduate training programs in medical sciences apart from the university setting. That is, any institution which is not within the university setup can start training postgraduate medical students, the aim being to increase the specialist human power in the country, of which we are very short of. We have approximately 400 institutions for that purpose. We are imparting training and conducting examinations. The second objective of the National Board is to conduct high quality standard examinations and set standards for postgraduate medical education. For each training course, we have well-defined curricula, well-defined examination procedures, and our graduates, postgraduates are respected all over the world because we are a national body and our standards of examinations are uniform and quality standard. Our candidates can compete with anyone in the world. So that has been the basic aim, objective and contribution of the National Board of the Examinations.
Thank you, Madam. I think we will all agree that the basic purpose of this collaboration is to provide the quality medical education to our medical fraternity. Thank you very much, Madam. Now I will request Dr. A.K. Sood, Executive Director of National Board of Examination, to tell our viewers about the continuing medical education programs of National Board of Examination. Dr. Sood.
Thank you, Professor Roda. As has been mentioned by our Vice President, over the years our activities at the National Board has expanded, and right now we are offering opportunities to our students in nearly 53 specialities. And these programs are being carried out all over the country through our 450 accredited hospitals, and every year we keep on adding nearly 100 hospitals. So the main purpose of these interactive CME programs, which we are starting from now, is to reach out to all the candidates and reach out to all our hospitals which are distributed all over the country. And as Professor Roda mentioned, that this has been made possible through the collaboration with the Indira Gandhi National Open University. They have a satellite-based infrastructure transmission system, and we hope that over the period all our hospitals who are there, they will install the reception equipment. Many of the hospitals are already acquired this, and many more are in the process of acquiring this. So our purpose here will be to have the best experts available, best consultant teachers available in the country, and they will be making clinical demonstrations for the benefit of our DNB students. And we hope that the students also will take best use of this opportunity, and they will ask questions, they will interact with them. I request all the DNB hospitals, especially the DNB coordinators and directors and also the students, to cooperate in this. And we do hope that this joint collaboration, ultimately our DNB programs will be improved, the quality of training will be improved, Let me mention at this stage that all these programs, interactive programs, to begin with, we are going to start once in a month, but gradually we are going to make it more frequently. And all these programs will be recorded, and maybe we'll edit it and provide to all our hospitals in the form of DVDs later on as a learning material. Thank you very much.
Thank you, Professor Sood. I think Professor Sood is also mentioning that the basic purpose of this joint venture of IGNOU and school and National Board of Examination is to provide the quality education and to reach to the unreachable. As he mentioned that we'll be having so many centers, and let me tell you that in days to come, maybe in a month or two, we are going to have DTH system also, which you need not to go to any particular center. Sitting at your own home, you can watch this teleconferencing session, and from your own home you can ask questions. And the basic purpose of this teleconferencing session is not to provide you the theoretical component, but to demonstrate you the practical skills and to have interaction. If there are some doubts, you keep on asking to us through your telephone, and we'll be just reflecting our telephone, toll-free telephone numbers and the fax numbers on the screen. You can see that, and you can call us anytime you feel like. The basic purpose is not to make it one way, because that can be done in the classroom situation and other places. But the basic purpose is to make it more interactive, and we'll also look forward to your suggestions and your comments in improving these types of activities. Now I request Dr. K.M. Shyam Prasad, Vice President of National Board of Examination, to tell about the faculty development program of the National Board of Examinations.
The National Board of Examination has recognized that medical faculty in this country do not receive the specialist medical education techniques that are required to teach medical students and postgraduate students. All other disciplines of education require the teachers to undergo an additional training to become teachers and learn the techniques of teaching. National Board, having recognized this, has been doing a number of workshops and training programs all over the country, including research methodology for its postgraduate teachers in its various institutions. And this is part of our program to improve quality of medical education. And we hope that in the future that we will use the satellite communication medium to educate medical educators all over the country on how to improve their methods of teaching and bring about high quality medical education, both undergraduate and postgraduate medical education in this country.
Thank you, Dr. Shyam Prasad. I think his focus is also on the improving of the quality of medical education through the faculty development. I think this medium can be exploited for that purpose also, and in future we will try to organize some teleconferencing sessions for the faculty of the NBE and other faculty members of the medical colleges. Thank you very much, sir. So I think this is just giving you the overview of why this collaboration and what is the purpose of this collaboration. And let me tell you a little bit about the School of Health Sciences also. The School of Health Sciences is offering few medical programs. The first program which we launched was PG Diploma in Maternal and Child Health, and this is of 1 year duration. And then subsequently we launched other programs like Postgraduate Diploma in Hospital and Health Management, which is also of 1 year duration. And then there is another program which is known as Postgraduate Diploma in Geriatric Medicine. This is also 1 year diploma program. Recently we have launched 2 years PG Diploma program in Community Cardiology. This is a residential program of 2 year duration, and all the MBBS graduates are eligible for this. And we have got a 6-month certificate course in hospital waste management also. So these are the few programs which School of Health Sciences is offering, and I think jointly we'll be expanding into other areas also, because the basic purpose, as I see the remarks made by the vice presidents and the executive directors, is that improving the quality of the medical education in the country and exploring the other areas in which of social relevance or of the national importance. So now, without wasting any further time, we'll go on to our technical session. And in the technical session, friends, we are going to discuss about the examination of a surgical case, and we have two experts with us, Dr. Kanduria and Dr. Kakkar. I will request Dr. Kanduria to start the clinical session first, which is on the examination of abdominal case.
During the next 45 minutes, we will take you through history taking and physical examination of the abdomen. Following this, there can be an interactive session with you all where you can ask questions regarding the case that we have just discussed. Now, the purpose of this exercise is to revise with you and to inculcate in you the basic fundamentals of physical examination. Despite rapid advances in diagnostic techniques, I think physical examination or clinical examination remains the cornerstone on which good patient care rests. So with these few words, we will move on to the clinical presentation. Dr. Amit Malhotra, resident in surgery, who will be presenting this patient with abdominal complaints.
So Mr. Rom Tarang is a 56-year-old male resident of Delhi, manual worker by occupation. He presented with abdominal distension for the past 8 months. History of presenting illness: he is a known alcoholic who was apparently asymptomatic 5 years back when he had multiple episodes of blood-stained vomiting associated with the passage of black-colored stools, for which he was admitted in a hospital and also received blood transfusions. After the hospital stay, he also underwent endoscopy and banding was done. After that episode, he was asymptomatic till 8 months back when he noticed abdominal distension, which is progressively increasing. It is associated with swelling of both the feet and dyspnea on exertion. The dyspnea gets partly relieved with the tapping of the fluid from the abdomen, which has been done 4 times in the past 8 months. The abdominal distension is also associated with passage of high-colored urine, and there is no further episodes of any blood-stained vomiting or passage of black-colored stools. He has been on regular medicines for the past 8 months for the distension of the abdomen. There is no history of any chest pain or palpitation, no history of any passage of hematuria. He has early satiety which is associated with the abdominal distension, and he has lost about 9 kg of weight in the past 5 years. Past history, sir. Past history: he is a known diabetic on insulin for the past 10 years. 22 units he is taking in the morning and 12 units in the evening. No history of any hypertension, no tuberculosis, bronchial asthma. Personal history: he was a known smoker and alcoholic. He was taking about daily he was taking alcohol about 1 peg per day, for which he had taken for the past 40 years. And he was also a smoker, and both of chronic smoker. He was smoking about 10 cigarettes per day, which he had stopped for the past 5 years after this episode. And his sleep is normal. There is no alteration in the sleep rhythm. And so on examination.
In the history of present illness, is there any history of any drug intake?
Sir, only the medicines he has been prescribed by the doctor.
Preceding the bout of hematemesis that he has had, was he on any drugs?
No, sir. There is no history of any NSAID intake or any drug intake for any pain in the joints or pain anywhere else.
Was there any history of pain in abdomen preceding the hematemesis?
No history of any pain in abdomen.
Did he have jaundice at any time in his life?
No previous episodes of jaundice in the past.
Is it relevant? All these are relevant.
Yes, sir.
Was he at any time admitted with hepatitis?
No.
Or any liver disease?
No history. Prior to this, 5 years back, he was not admitted.
Besides banding, which you have mentioned, endoscopy and banding, has he undergone any surgical intervention?
No surgery in the past.
Now, when you mention about history of banding, you have to mention how many sittings he has had. Was it a banding? Does he know it's a banding, or was it a sclerotherapy?
Yes, sir. He is telling the band was applied.
the ban was applied? Once only.
Twice, sir.
Twice. He's never had any history of, and never lost any consciousness or any convulsions.
No convulsions, no loss of consciousness. No.
Has he lost, you said he's lost 9 kilograms
Over the
of
past
weight
5 years.
over the last 5 years. Is there any rapid loss of weight in the last few
No, sir.
months?
Gradually he has lost over the past 5 years.
Has he been married?
Yes, sir. He is married with 2
It's
children.
relevant to find out whether he's been married or not, and if he's married, whether he's got a children, especially a man who's been taking alcoholic, who's got a liver disease.
Yes, sir.
Because these disorders can affect the whole body. It's relevant, isn't it?
Yes.
I guess that's about history of
Present.
that's present, past, and history. Now you present the physical examination to Dr. Khanduri.
Sir, he is conscious and cooperative, moderately built and nourished, and there is a pallor present, icterus present, clubbing present, no cyanosis, no lymphadenopathy, bilateral pitting pedal edema is present. His pulse rate is 80 per minute, blood pressure is 120 by 80 in the right arm supine position, respiratory rate is 18 per minute, he is afebrile, and signs of liver cell failure, there is no flapping tremors. He has got
Can you just show us how you did the flapping
बैठ जाओगे?
right flap?
You make the arms have to be stretched. This joint has to be extended. Then wrist has to be extended. Both
Do it
wrists.
one hand.
And then you tell the patient to maintain with spreading of all the fingers. You tell the patient to maintain it in this position. If he's able to maintain in this position, then there is no signs, no flapping tremor, and no signs of any hepatic encephalopathy. Then he has got pulmonary edema present on the hypothenar and the thenar spaces. There is no dupitant contracture. He has got no alopecia. There has got bilateral parotid enlargement, and there are spider and nevi which are present, and he has got bilateral gynecomastia. There is palpable breast tissue beyond the areola, and he has got testes which are decreased in size. Abdomen examination, sir. On inspection,
What are these spider nevi?
sir, spider nevi are basically capillary arterial dilatation, which occur because of the hyperestrogenism, which occurs in the patient of alcoholic liver disease. It is because the androstenedione, which is produced from the adrenal, it doesn't get it gets converted into the estrogen, and that causes peripheral dilatation of the arterioles.
How do you demonstrate?
We take a pin, and then when we put a pressure on this arteriole, it will disappear, and as soon as the pressure is released, there will be filling from the peripheries. There will be filling of the arteriole with the
From the center,
from the
it starts filling from the center,
yes, sir.
and then goes to the
Goes to
periphery. Yes.
It is not because of increase in level of estrogens. It's because of disturbance in the ratio between a free testosterone and or free androgens and estrogens. Overall, the levels are not significantly raised. And second reason is the androgens get converted into estrogens at the periphery, so the ratio gets disturbed. It's not because of absolute increase in the level of estrogens.
Okay.
And it's not hypothenar and thinner spaces, thinner and hypothenar eminences.
Eminences.
What about the jaundice? You said he's jaundice. Where did you look for the jaundice?
Sir, we will look in the bulbar conjunctiva. We will tell the patient to look down and then see for in the bulbar conjunctiva.
And what are the prerequisites of?
It has to be seen in a bright sunlight, and
Preferably natural light.
natural
Yes.
light.
What other places can you?
We can see, sir, in the mucous membrane under the base of the tongue. You tell the patient to open the mouth and touch the palate, and you can see under the tongue. You can also see on the soft palate, and if there is very high jaundice, it will be reflected on the body also.
Dr. Amit, you do not see in the soft palate. Soft palate is a muscular organ, and the pigments are not deposited in the muscles. You see it in the hard palate and a secondary hard palate. which is developed from the mandibular arch. You see on the under surface of the tongue, not the base of the tongue.
Floor.
Under surface of the tongue. You don't see on the conjunctiva, you see on the sclera.
Yes, sir. Sclera gets deposition because.
So you don't see the bulbar conjunctiva. It is the sclera. Yes.
He said sclera.
No, he said conjunctiva. You don't see on a bulbar conjunctiva. You see on the sclera.
Yes.
Because if you see on a bulbar conjunctiva, then it should be visible on a palpebral conjunctiva. It is a sclera which gives deposition of the pigments.
Yes.
Right?
Sir, abdomen examination. On inspection, abdomen.
Before you go to the abdominal examination, you should also mention about the jugular venous pressure and the muscle wasting, which these patients often are supposed to have.
You mentioned nothing about muscle wasting. That's very important. Muscle mass loss is depicts advanced
disease.
Yes.
Sir, on abdomen examination, on inspection, abdomen is distended, umbilicus is everted, flanks are full, all quadrants are moving well with respiration, skin overlying the abdomen is normal. There are no visible veins seen over the abdomen and no visible pulsations, no visible peristalsis. External genitalia, I've already mentioned the testes are decreased in size and bilateral inguinal orifices.
Inspections too.
Yes, sir. Bilateral inguinal orifices are normal.
Hernial orifices are normal.
Bilateral hernial orifices are normal.
So what is the significance of this umbilicus?
That means the patient has got tense ascites and which had caused eversion of the umbilicus.
So chronic, it should be over a long period of time. You get eversion of the umbilicus. So what are the things you're looking at when you're on inspection? You're looking at the contour of the abdomen, movement with respiration. You're looking at the position of the umbilicus, whether it's everted or deeply tucked in. Sometimes there will be metastatic deposits in the umbilicus, or there may be a granuloma in the umbilicus. These are things you're looking for. Then you're looking for visible pulsations
and peristalsis.
So where do you look for visible peristalsis?
Sir, peristalsis we will see if it is because of the gastric outlet obstruction, it will be seen in the upper abdomen where there will be peristaltic vein. Patient will say a mass of rolling mass is seen from left hypochondrium to the right hypochondric region. And if it is due to small bowel obstruction, then there will be a step-ladder pattern of peristalsis in the lower abdomen.
Yes. Then what about visible pulsations?
Visible pulsations, sir, will be seen basically in the center abdomen when we have transmitted pulsations, or if the patient has some fistula, then only we will be able to see pulsations.
Or aneurysm or a very vascular tumor, they will be pulsatile.
Which fistula produces pulsations?
Only prominent veins will be there, sir.
Not veins. You can't see the pulsations in a vein. It has to be some arterial pathology. And transmitted pulsations from heart are not seen in the umbilical region. They are seen in the epigastrium.
Region.
You don't see transmitted pulsation in the heart in the umbilical region.
What venous enlargement were you looking for?
Sir, I was looking for any caput medusae in this patient.
What is caput medusae?
Caput medusae will be because of the portal hypertension. There will be portosystemic shunting occurring place between the portal system of veins and the inferior and the superior epigastric veins. And due to which,
so here what is it in caput medusae?
There will be flow from umbilicus towards the
periphery. But which vessel is involved? Portal. Which is the portal vessel?
That will be the paraumbilical vein, which is coming from the left branch of the
vein, which comes from the
left branch of the portal vein.
Yes, normally it obliterates.
It's obliterated, but in the patient
later on has portal hypertension.
It has opened.
It recanalizes and anastomosis with
the superior and the
superficial superior epigastric
and inferior epigastric veins.
Yes.
And I was also another veins. If any periphery, there are veins which are seen.
Suggestive of?
There will be suggestive of IVC obstruction. If there
yes.
The flow will be from below upwards.
That's right.
What about renal angles? I think while you're doing inspection, it's good to look at the renal angles. Sit them up and see if there's fullness of the renal angles. That may suggest that there is a swelling. Okay, now you can go on to palpation.
Sir, on palpation, abdomen is soft. There is no tenderness, no guarding, no rigidity, and no rebound tenderness. The liver is not palpable. Spleen is palpable 2 centimeter below the left costal margin in the spino-umbilical line. The anterior border is sharp. The splenic notch is felt. There is no other mass which is felt. On percussion,
still on palpation.
What else on? How do you palpate the spleen?
Sir, spleen is palpated. I will keep my left hand under the left costal margin, and then in the spino-umbilical line, I will start from the anterior superior iliac spine, go towards the left costal margin with my index finger parallel to the left costal margin, and I will tell Rom, उधर move करो, मुंह से सांस लेना है, ठीक है? With each inspiration, I will feel the notch of the spleen, and with each expiration.
How will you feel with each inspiration?
Sir, in this patient it is.
That's when you reach the spleen.
Spleen.
So
yes,
you inch your way forward.
With each breath, I will move forward. With each expiration, I will move forward, and with each inspiration, I will feel the for the anterior border of the spleen. In this patient, it is
sharp border, palpable.
It is just palpable, sir, 2 centimeter below the left costal margin in this patient.
Can you feel it better in any other position?
Yes, sir. If I can feel better by turning the patient in the right lateral position, and then feel in the similar manner, because with that the anterior border might come more interiorly and it will be better felt.
What is the normal extent, anterior extent of the spleen?
Normally, sir, it will be. It won't be palpable. Normal spleen.
What is the normal extent of the spleen? Anterior extent of the spleen.
Sir, it is just along the 10th rib axis.
10th rib axis. That's all
right.
To
where? Which part?
Or to which line?
It will be just up till the anterior axillary line.
No, it does not exceed the mid axillary line. If it exceeds the mid axillary line, that means the spleen is already enlarged. Because the spleen first grows superiorly and posteriorly.
Yes.
So after it has completed that space, it starts growing downwards and towards the anterior side.
Yes.
So mid axillary line is the normal anterior extent of the spleen.
The other point is that the spleen often is much more lateral than you imagine it to be. So you must go right laterally.
In the
very often it is palpated there.
Okay, sir.
Why is this not a kidney? I feel this is the kidney.
Sir, I cannot insuate my fingers.
What are the points? How do you differentiate a spleen from kidney?
Sir, in a splenic enlargement, we felt much more interiorly. You cannot insuate your fingers between the spleen and the costal margin. And
can you insinuate between the kidney and the spleen?
You can insuate.
Okay. Yes.
And then splenic notch will be felt. On percussion, if you percuss the spleen, it will be dull. And if you percuss...
No, still on palpation.
Palpation. And
what differentiates the spleen from the kidney?
Both moving with respiration, but splenic movement will be much more with respiration. Yes. And
you cannot insinuate your fingers. Yes, you have a border. I think any swelling in the left upper abdomen which has a border, even if you don't feel the notch, should be taken to be spleen unless you otherwise prove it.
Yes.
Okay. It's better felt anteriorly than
kidney.
Than kidney, and the kidney never crosses the.
Then it never crosses the midline.
Whereas this goes towards the umbilicus and may cross the midline.
Yes.
Then on percussion, tell us.
Sir, on percussion...
Can we interrupt him for a second? What is the hallmark of a kidney swelling which separates it from a spleen?
It is bimanually palpable.
Spleen can be bimanually palpable.
Kidney can be, sir, bimanually palpable.
What is the hallmark of a kidney swelling?
Ballotability.
Yes, the spleen is
bimanual.
not ballotable. A big spleen can be bimanually palpable,
Palpable,
but it's not ballotable. Whereas kidney is both ballotable
and
as well as
bimanually
the
palpable.
fact that it's ballotable is a bimanually palpable.
Yes, sir.
Okay.
Sir, on percussion, there will be dullness present over the splenic mass, but because of
Now
the
we are talking. Now you come to the percussion of this patient. What about the liver? Is the liver palpable?
no, sir, liver is not palpable.
Okay.
No, you said differentiation between the
Spleen and the kidney.
So on percussion, what is? Then we'll come back to percussion.
So on
Percussion,
percussion
it will
of the splenic mass, there will be dullness over
Yes.
the splenic mass, but because in the kidney mass, because there will be a band of colon over it, so it will be resonant.
Yes.
And, if
and
you-
what else? No, that's not enough.
If you make the patient in the sitting position, you can also,
No, spleen.
then the dullness will be continuous with the,
With the normal splenic
enlargement.
dullness.
Dullness with the
Huh?
monosplenic dullness.
Which is where? Where do you get the normal
sir.
splenic dullness?
It will be continuous from 8-9 spaces above. Yes.
It's not 8th. The normal spleen is related to 9th, 10th and 11th
sir.
rib.
But when
So along the axis of 10th rib
Yes, sir.
or 9th intercostal space, if you percuss backwards, you will find that is continuous with the area of splenic dullness.
So, but when it enlarges, it will first fill the 8 space, and then this, and then it is, so that is why it will go to 8 space also.
That's
If there is
okay,
a-
but normal is
Normal is
9th,
from the
10th
9th.
and 11th.
Yes, sir,
So
9th and
it is continuous with the splenic dullness.
Splenic dullness.
Yes. And in the case of kidneys,
In the case of kidneys, sir, it won't be continuous upwards. There will be a resonant again coming under
there
the
will be
costal margin.
resonance anteriorly because of the colon.
Colon, yes, sir.
And what about the renal angle?
Renal angle, when you make the patients in the sitting posture,
Mm.
if you percuss in the renal angle region, it will be dull when there is a renal enlargement.
No.
Kidney enlargement, there will be
See,
dullness.
why is there dullness or resonance in,
Sir,
in the
normally-
renal angle?
Transverse colon lies in that area. But because of the splenic because of the kidney enlargement, there will be dullness in that area.
So it's actually you have to compare the two renal angles.
Yes, sir.
Because whether it's resonant or dull will depend upon the amount of air there is in the colon,
Yes, sir.
in the flexures.
Yes, sir.
Okay? So when you look for dullness or for resonance, you got to always compare it with the other side.
Yes, sir.
So it will be dull compared to the other
Opposite side,
renal angle. And you always examine the patient in the
sitting position.
sitting position because
Sir, because then only the gas will come up.
yes, the air will rise to the flexures
Yes,
and you will be able to elicit the sound
Yes,
properly.
yes.
So always in comparison. And it depends upon the amount of air in the
colon.
colon. Yes, percussion, go on to percussion.
Sir, on percussion, upper part of the liver dullness is present in the 5th intercostal space in the mid-clavicular line, and there is a shifting dullness is present. And sir,
Can you demonstrate shifting dullness?
sir, for shifting dullness, you start from the epigastrium.
Why do we start from the epigastrium?
Sir, because it is always from the dull to a tympanic region. When the fluid
You
occurs,
go from dull to a tympanic or tympanic to a dull?
sorry, so we have to get the area of maximum tympanism. That is why we start from epigastrium.
You want to get a maximum area of tympanism? Tympanic is above or tympanic is below? If there's
Sir,
a fluid, where is tympanic?
Tympanic will be in the midline.
When you do it from epigastrium, you want to find out where is the upper level of the fluid.
Yes, sir.
So you go from tympanic to dull, not from dull to tympanic.
Yes, sir, but we have to know which is the most tympanic area, and then only, because fluid, when it gets accumulated in this shape, and then more will be in the flanks. To know the area of maximum tympanism, we start from tympanism to dull area. It is always percussion is from tympanism to dull area.
That's
That's
okay.
what he's saying.
That's
He's
what I'm saying. But when you want to start percussion, why do you start from epigastrium? That's what I'm asking you. Why from epigastrium?
I want to know the maximum tympanism. From there only I will start.
So maximum tympanism is normally in the epigastrium because,
So
the
because
stomach.
there is also costal margin here, so I cannot.
No, if you start from epigastrium down, so that you can find out the upper level of the fluid. If the fellow is dull here, then there is no point doing anything. There is no shifting dullness. Then you have a fluid thrill. Because the whole peritoneal cavity is full of fluid, so you will not get a shifting dullness. Shifting dullness is only possible when there is a space in which the intestines are floating.
Yes, sir.
If they're completely filled by a peritoneal cavity, the fluid is filling up the whole peritoneal cavity, there's no shifting dullness. Right?
So that is why you come from
Above to downwards. तो ये करेंगे प्रकृति, ठीक है? So this is the maximum temperature.
Yeah.
This is the starting point, and this is.
Okay.
Then I will. This area is dull.
That's
go,
right.
Go
That's
further.
good.
Go further down. Yes.
Okay.
Tarang.
थोड़ा उधर घूम जाइए. Then
you wait for 30 seconds for the intestine to float up and the fluid to settle down, and you will go from this dull area, which should become resonant, tympanic,
Okay,
and
resonant and tympanic is the same thing.
Yes.
ਇਸਨੂੰ ਮਜ਼ੇਦਾਰ ਬਣਾਉਣਾ ਬੱਚਿਆਂ ਨੂੰ ਸਮਝਾਉਣ ਦੇ ਲਿਹਾਜ਼ ਨਾਲ ਬੜਾ ਜ਼ਰੂਰੀ ਹੈ, ਨਹੀਂ ਤਾਂ ਬੱਚਿਆਂ ਦੀ ਦਿਲਚਸਪੀ ਤੁਸੀਂ ਜ਼ਿਆਦਾ
This has
ਦੇਰ
become
ਤੱਕ
dull.
ਕਾਇਮ
Go
ਨਹੀਂ
further.
ਰੱਖ ਸਕਦੇ.
Dull, sir.
You should tilt the patient in the opposite direction and repeat the process.
It should be done on both sides. Yes, go ahead.
It has become tympanic.
Should repeat it because sometimes the colon on one side may be loaded and may give you a false impression.
So you should do shifting dullness on both
the
sides. Right? No, one side is not enough. Okay.
Similarly, I have to do on the right side.
Yes.
Shall I demonstrate?
No, that's okay.
No, that's all
okay.
right. You've demonstrated. You should do it both left and right. If there's a small amount of fluid, any test you know.
Yes, sir. I can do puddle sign.
What is that?
That is, you can make the patient in the knee elbow position, and then you keep your stethoscope over the umbilicus, and then you do tapping from the anterior abdominal wall.
No.
So there are two ways described. One is ausculto-percussion method.
Are you talking about percussion?
Okay.
You have not gone on to the auscultation as yet.
Yes, sir. In percussion also, you make the patient in the knee elbow position. You start from the lateral towards the.
No. What happens when you
Then
have
it
the
will become
patient?
dull. If there is.
What happens when the patient is in the knee elbow position? What happens to fluid?
Yes, sir. Fluid will accumulate near the
At the
umbilicus.
most dependent point, which forms a puddle there. So, and then you percuss near the umbilicus. You percuss the most dependent part. And if it is,
If it becomes dull, then means there
then
is a
there's fluid. Okay. How do you differentiate between insisted fluid and free fluid?
Yes, sir. Sir, in insisted fluid, there will be no shifting dullness.
Yes. What will there be?
There will be dullness which is present to the confined to one place. That means that area has been loculated, and there will be insisted fluid.
Dullness alone is not a.
There can be fluid thrill if it is completely
Fluid thrill, yes.
encasing it. Completely encasing the peritoneal cavity, then there can be fluid thrill, but there won't be shifting dullness.
Yes. How do you demonstrate fluid thrill?
Fluid thrill, I can tell the patient to keep his hand over the in the midline, over the anterior abdominal, or a third person keeping his hand in the midline, and then I will keep my hand, left hand on the left side, and tap from the right side, or it can be done other way also, and feel for the fluid pushing against my hand. This hand just prevents the transmitted pulsation from the anterior abdominal wall coming to the opposite hand.
Not pulsation. Transmitted thrill
Yes.
through the anterior abdominal wall.
Transmitted thrill.
Percussion thrill may be transmitted along the abdominal wall. That you provide.
Yes, sir.
Yes. What else do you percuss?
Then I also percuss for the spleen.
Yes. Where do you normally, if the spleen is not enlarged?
Then I will start dullness only in the 9th intercostal space. 8th intercostal space will be resonant.
Where do you start from?
I will start from the 4th intercostal space, and then go on
Okay,
downwards.
then what is the posterior extent of your percussion?
Sir, I will percuss in the anterior axillary line.
No, that is up to the anterior mid-axillary line, but posterior extent.
Posterior extent is till the posterior axillary line, sir.
No, that's the size of the spleen.
No, sir.
You start from parascapular and come down anteriorly.
Parascapular line come down to anteriorly to the mid-axillary line. That's the normal 9th and 10th space.
Parascapular. रोम तक इधर हो जाओ. इसको यहाँ रखा. I will start from sir posterior axillary line.
Where is posterior axillary line?
Posterior axillary line is this.
Yes.
So he's just told you parascapular.
Start
And you
from
are insisting-
parascapular.
Yes, this is where you go. It's
I will count this. This is the 10th intercostal space. This is dull.
No, your hand should be at right angle to the intercostal space.
Yes, sir.
Start from here and then come down anteriorly. You've gone below the 12th rib. You're going too low down.
okay. So you come up to the mid-axillary line. If it goes beyond, as Dr. Kakkar just said, goes beyond the mid-axillary line, it means there's enlargement.
Yes, sir.
Yes, you want to ask a
Auscultation, sir. Bowel sounds are present. There is no bruit heard.
Where do you hear a bruit?
So normally we hear it on the liver.
What sort of a bruit is that? And why do you get a bruit?
So because of the increased vascularity of the in that only happens when the patient has turned into malignancy. Then
No, in a patient with portal hypertension, do you hear a bruit or not?
no.
Sure.
No, sir. Normally
You do hear a venous hum at the umbilicus, and you do get a bruit in the liver because of shunting.
Shunting. Yes, sir. But in this patient, sir, there was no caput medusa, so there was.
You may not have a visible caput medusae. Patient can still have venous hum.
Okay,
You should auscultate all cases of cirrhosis of liver or portal hypertension for venous hum and a bruit in the liver. Sometimes you can get a hepatic rub because of subcapsular hemorrhages.
Yes, sir.
They may produce a rub, what is called as hepatic rub. Similarly, you can get a splenic rub in portal hypertension because of subcapsular hemorrhages and fibrosis in that area.
infarction.
And infarct.
Yes, sir.
Yes, then what else? You said bowel sounds, you must see whether exaggerated.
Yes, sir. They were normal.
They are normal.
Normal.
Say that. You must say, bring it out as a negative point.
Bowel sounds are normal.
Yes.
So digital rectal examination, rectum was empty. There was no clay-colored stools and no blood stain.
If it was empty, where is the question of clay-colored stools?
Sorry, sir.
Huh?
The examining finger, there may be some stools, right?
Staining was no staining was there,
So-
neither
so
of
that's
blood
what you must say.
and no evidence of clay-colored stool. And respiratory system examination, sir, bilateral air entry was good, and normal vesicular breath sounds were heard. The CNS examination was normal, and
Was it necessary to do a CNS examination?
so because he's a patient of liver disease and he can go into hepatic encephalopathy. I've already checked for flapping tremors. There were no flapping tremors.
Yes. Flapping tremors is a very late occurrence, it's almost pre-coma.
Yes, sir.
What are the early
Yes.
signs of
Early,
neuropsychiatric
sir,
changes?
in the history I've told that there is no sleep disturbances.
Yes.
Yeah, and
No, I'm asking
there is no
physical.
slurring.
Physical signs.
Physical signs, what are you going to ask him?
Yes, sir. He was oriented to time, place and person.
Did you ask him?
Yes, sir.
What did you ask?
I asked him, क्या काम करते हो, कहाँ रहते हो?
कौन सा महीना?
July.
This is one way you can ask him whether he is oriented as what day it is, where he is.
Yes, sir.
Which year it is. Sometimes these people may not know. These are the early. You can ask them to add.
Yes, sir.
One other thing is to make points on a piece of paper, 1 to 20, and ask him to join these lines. 1, 2, 3.
Understood,
You'll find they have difficulty. One easy way is to ask him to write his name every day and his address.
We can find out the...
And then you can look after 2 weeks when he comes whether there is change. This is especially because you have to put these patients on a high protein
diet, yes,
and
sir.
they may go into encephalopathy. So this is one way of checking whether he is going into early encephalopathy.
So the CVS examination, S1, S2 were heard normal, there were no murmurs. And
do you expect murmurs?
Sir, because he is a patient of ascites with pedal edema, I wanted to rule out he is not suffering from any heart disease also. From the history and examination I have already made out.
Look like
why? What for do you look CVS? You are right to do it, but what do you want to see on CVS?
Sir, I have to rule out the cardiogenic cause for any edema.
Do a non-cirrhotic.
Non-cirrhotic, yes. Sir, he can have cirrhosis because of the back pressure. If there is any...
no, not likely to have a cardiac cirrhosis. It doesn't have any features of cardiac. You want to, the commonest thing is you may get
volume overload.
You may get a functional murmurs. Because of anemia and hyperdynamic circulation.
Yes, sir.
The valvular disorders normally are not associated with the cirrhosis, and you want to exclude any effusion into the pleural cavity. That's about all that you want to do it.
Yes. Rectal examination is a very important part of that you have done. Now, so based on your history and physical findings, what is your provisional diagnosis?
So my diagnosis is alcoholic liver disease, probably cirrhosis with portal hypertension and ascites with diabetes mellitus.
Why do you say all this? Why is reasons for your diagnosis?
Sir, he is a known alcoholic and he has history of variceal bleeding and he has a splenomegaly and and he has ascites. So these all are features suggestive of portal hypertension and cirrhosis because liver is also not palpable. And
would you say this is decompensated or is it well compensated?
He is presently in a compensated state, sir.
Why? He's got ascites. He's got refractory ascites. It's not settling.
Yes, sir.
How can you say it is decompensated?
Decompensated. Yes, decompensated.
Now, what investigations will you do?
Sir, my investigations will be biochemical, hematological and radiological. Then biochemical, in the hematological I would like to do his CBC. What is his hemoglobin? What are his counts?
What are you looking in CBC?
I want to rule out hypersplenism.
What happens in hypersplenism?
Sir, in hypersplenism he will have pancytopenia. He will have low hemoglobin, he will have low counts.
Okay. Yes.
And then I would like to do his LFT to know his liver function. What is the albumin? What are his enzymes? What is the prothrombin time and activated partial thromboblastin time? And then I will do his electrolyte status, what is sodium and potassium, and then ascitic tapping, what is the ascites, whatever, probably he will be having probably transudate only, and then ultrasound of the abdomen. In radiological I would like to do ultrasound of the abdomen. Ultrasound of the abdomen to know the ecotexture size of the liver and what is the portal vein diameter, what is the splenic vein diameter, any portal cavernoma formation, what is how splenic enlargement. Then also it will also tell about the fluid in the abdomen.
You know your spleen is enlarged already.
Yes, sir.
So why are you looking at diameter of vessels?
Sir, if we are planning for shunting in this...
No, are you planning for shunt in him?
Sir, only when if he is decompensated, if this refractory ascites is not settling and he has got repeated episodes of hematopoiesis, then only. Otherwise, I am not considering.
What happens when you do a shunt?
There is a risk of encephalopathy.
Yes. The liver already has a poor blood supply. You are shunting away whatever little. So there is really no place for shunting in a cirrhotic, that too alcoholic cirrhotic. You can do shunting or tips, what they refer to as.
Yes, sir.
That can be done for as a bridge to
transplantation.
But it's not. You won't do a shunt. What would you do?
Sir, I will initially manage him medical management for this patient. I will give him a low salt diet, about 2 grams per day, high protein diet, and fluid restriction, about 1 liter per day, 1 to 1.5 liters per day, and then I will give him a spironolactone tablet, which is I will start with 25 milligram TDS. I can go maximum till 400 milligram per day, and I will also give him furosemide, tablet furosemide, 40 to 80 milligram per day, and I will give him vitamins, and
the question is, what are you preparing him for? He's got a refractory ascites. What surgical intervention do you recommend for him?
Surgical treatment is only transplantation.
Liver transplantation. That's right.
And if he has bleeds, then you treat it by either sclerotherapy or banding.
Banding, yes, sir. Sclerotherapy and banding.
There's no other treatment for him.
Yes, I think all cirrhotics, decompensated cirrhotics plus 50 are bad candidates for shunts. Young cirrhotics, compensated, can be considered for shunts. Of course, today with the availability of banding and sclerotherapy, shunts are going out. But if at all you have to consider, they are only for young patients, not for above 50 and decompensated at any stage. Spontaneous bacterial peritonitis, resistant ascites, decompensated liver function above 50 are the candidates for transplantation.
Friends, just now you have seen the case presentation by Dr. Amit Malhotra before Dr. Khanduri and Dr. Kakkar. I think it has been a very elucidative presentation, but still, if there are some questions, now the topic is open for discussions. You can give calls on our toll-free number and other studio number, and you can also fax your questions and queries through fax also. And when we'll be having a break after 12 o'clock, during that also you can send your faxes, and which will be able to answer after the break also. Now the session is open for discussion. Any questions from the studios? Any question from the students sitting at the various regional centers or various other receiving centers? Any questions from the studio? Yes, that's how you identify yourself and then your.
Dr. Ravinder, I'm doing my GMB in General Medicine in Bulchan Hospital. I just wanted to know, in a cirrhotic patient, he did not mention about the liver span, and if the liver is palpable, I would like to know what we should be describing about the softness, tender liver, the borders, surface.
You know, the fact that this patient liver is hardly palpable, there's no question of describing the surface and the tenderness.
So not only in this patient, I was asking.
And
but
when you talk,
if it is not palpable and we're thinking of cirrhosis, shouldn't that liver span be calculated?
Yes, you should calculate the liver span, because in late cirrhosis, the liver is generally contracted. So there is no, obviously he should have said the liver span, was it normal or was it contracted? It's an important part of the diagnosis.
Call from Nagarpai.
Thank you.
There is a call from Nagarcoil. Yes, Nagarcoil, please come up. Yes, please. I think it got disconnected. I think we can continue, Dr.
No, I think he's here. Is that all right? Liver will be contracted.
Yes, there is a call from Guwahati. Yes, Guwahati, please come up. Yes, Guwahati.
I want to know how do we test for flapping tremor?
Can you identify yourself, Dr. Saab?
Sir, I am Dr. Archana. I am doing DNB medicine at Downtown Hospital.
Dr. Archana. Sir, would you like to?
As Dr. Amit has demonstrated, you ask the patient to extend the arms and dorsiflex the hand with the fingers splayed out. If a patient can maintain that status of the hand or the position of the hand, obviously he doesn't have a flapping tremors. A patient who's got a flapping tremors, the hand would gradually start falling down. That is how you elicit the flapping tremors. And flapping tremors are present in many conditions other than plain simple.
Sir, there is a call from
hepatic
Cochin.
failure.
Yes, Cochin, please come up.
I'm Dr. Prashant Pandey here from Cochin.
Yes, Dr. Prashant Pandey. What is your question?
I'm doing my DNB in family medicine
Okay, Dr. Saab, what?
at INHS Sanjeevani.
Yeah.
I just wanted to ask one question, that is, Dr. Kakad offered liver transplant in this case, but does this patient meet the criteria to be offered?
Sir, his question is that,
Are there any specific criteria?
his question is that you just suggested that the liver transport should become, you
The
want to...
criteria, end-stage liver disease, in a nutshell, is the criteria for transplantation. End-stage liver disease, and that includes refractory ascites, spontaneous bacterial peritonitis, of course loss of muscle mass, muscle wasting, all these are bad prognostic factors. But age beyond a certain, in the West where they do a lot of transplantation, age is not really a contraindication. They are transplanting 70, 75-year-old patients. But I think in our early phases, early stage, what we have in India, I think a young patient over the age of 50 as Dr. Kakar just mentioned, I would be reluctant to take. But end-stage liver disease, there is loss of synthetic function, there is spontaneous bacterial peritonitis, and if there is refractory ascites, these are all indications for liver transplantation.
Sure.
Give her the mic.
I'm Dr. Kirti Jain and I'm doing DNB in Gaini from Mulchan Hospital. So being concerned
Yeah, just hold on. There is a call from Ahmedabad. Let us... Yes, Ahmedabad, please come up.
The doctor from cardiology department, he is attending the session. Please hold on.
Good afternoon.
Good afternoon.
I'm Dr. Kamal Sharma. I'm assistant professor in cardiology.
Yes, Dr. Kamal.
I'm accompanying here with my wife, Dr. Neha Sharma. She is doing DNB medicine. My question is, shouldn't the etiology of cirrhosis alter whether, irrespective of the age, as to whether the candidate is fit for transplant or not? For example, if the etiology is post-necrotic for like post-hepatitis B or post-hepatitis C, even in young patients, won't the etiology come into a factor as to whether the patient should go for a transplant even in refractory ascites or not?
Not necessarily, no.
Thank you.
Many patients with hep C cirrhosis are being transplanted. Even hepatitis B patients are being transplanted.
Just wait.
So that is not a contraindication for transplantation.
There is a call from Faridabad. Yes, Faridabad, please come up.
Hello?
Yes, please.
Hello?
Yes, please.
I'm Dr. Jitendra here from Scott Faridabad.
Yes, Dr. Jitendra, what is your question? Yes, Dr. Jitendra, what is your question?
Can you demonstrate, please? Can you demonstrate venous thump and bruise?
I'm afraid this patient doesn't have a venous hum or a bruit. If we have a case in future, we'll definitely record it and play it for you. All that you have to do is put a stethoscope at the umbilicus and patiently listen to a soft murmur.
Yeah. Okay, I think Dr. Jitendra, at the moment we don't.
Hello.
Yes. Yes.
Myself, Dr. Vikas from Faridabad.
Yes. So, Dr. Vikas, what is your question?
Sir, I have a question. In a case of cirrhosis, how do you differentiate between hemorrhoids and varices?
The varices of the rectal region are, in other terms, called hemorrhoids. Though people say that in portal hypertension hemorrhoids are often seen, that's not true. There is a shunting there, portosystemic anastomosis, but for reasons not well known, hemorrhoids are not significantly higher in cirrhotics. And the terms are the same, whether it is you say hemorrhoids or you say the varices there.
We have got a call from Chennai. Yes, Chennai, please come up.
Hello.
Yes.
Hello.
Yes, please.
We are from the OG department. I just want to know, sir, whether you're having OG program today.
Which program? Yeah, we will be having.
Obstetrics and gynecology.
Yeah, we are having after 2 o'clock.
No, sir. No.
Not today. Thank you, sir.
No, for our School of Health Sciences program.
Okay.
Okay. I think, Dr. you were telling before
this
I interrupted
point about hemorrhoids.
Yeah.
Hemorrhoids they are cushions, there are 3 cushions which are present at 3, 7 and 11 o'clock positions. And it is, the hemorrhoids occur in those positions. Whereas the rectal varices do not necessarily occur in those positions. They are different, but they rarely occur because perhaps the distance is so far that the back pressure is not transmitted.
So there is a call from Calcutta. Yes, Calcutta, please come up. Yes, Calcutta.
Hello,
Yes, please.
this is Dr. Shonchita from Kolkata.
Yes, Dr. Sunita.
May I ask you, what are the things which should be considered in the differential diagnosis of such a patient?
I think she is asking for differential diagnosis of this case. Dr. Kakkar,
Well, taking to totality of this patient, that is, he is a known alcoholic, he has got ascites, he has bled early, so obviously he has got an alcoholic disease. If he didn't have a history of alcoholism, you would have thought of other causes of portal hypertension in this patient. Basically, one has to think of a differential diagnosis related to liver cell failure resulting in portal hypertension.
But the final diagnosis is always made. Any patient should ideally have a liver biopsy, because a cirrhotic from some other cause could also be drinking alcohol and he may not have alcoholic cirrhosis. So for the ultimate diagnosis, I think a liver biopsy is very important. Now, in the presence of ascites, you don't do liver biopsies because you may have bleeding. But in such patients, in good centers, you could do transjugular liver biopsies.
Sir, would you like to sum up the case? Because we have got a lot of questions. Would you like to sum up? Because we have to close transmission for half an hour. And can you sum up that?
Dr. Arun Kakkar will sum up.
So to sum up this case, in totality, when you're taking a case of abdominal pathology, especially if it is related to hepatic disturbances, in addition to asking a specific questions related to the disease that he has come, you have to take history of diabetes, hypertension, tuberculosis, relevant past admissions, any treatment, any transfusions, any jaundice, any surgery in the past. When you examine these cases, you have to look for presence of liver cell failure, you have to look for liver spleen, you have to look for presence or absence of splenomegaly, you we have to look for free fluid in the peritoneal cavity, plus the routine examination without which the abdominal examination is incomplete, that is supraclavicular fossa, because when a cirrhotic can have a malignancy and can have a lymph node in the supraclavicular fossa, a spine, a internal examination like per-rectal examination in the male or a per-vaginal examination in a lady. That completes the examination of a patient with abdominal pathology, especially if it is liver cell disease.
If I may just add one sentence, I think the greatest clinical skill is to listen, just to listen. If you listen to the patient, he is invariably telling you the diagnosis.
Sir, I think before we break for the tea, there is one question from the audience.
Yes.
So let us take that question. Yes.
Yes. I just wanted to know that how do we distinguish between spleen and a gravid uterus? Or how do we go about examination of the spleen, suppose in a lady with a 32 weeks old uterus?
You see, for uterus, you are from gynae, you know more than I know about it. You always start palpating from epigastrium and go down.
No, so the thing is, like, we have had so much of emphasis on the splenic examination, the span of the spleen, till which person margin we should go. So, like, suppose if we get a case like this with ascites, with hypersplenism, how should we go about the examination of the spleen? Of course, we know the fundal height from the examination. So, how should we comment on the spleen?
Well, you examine the uterus separately and spleen separately. Examination of spleen is the same whether the patient is pregnant or non-pregnant. You have to describe it two lumps, that in addition to having a uterine enlargement because of pregnancy, patient has got a splenomegaly, and the cardinal features of splenomegaly as he is described, yes, moves well with the respiration, has got a notch, the dullness continues with the splenic dullness, is generally not bimanually palpable, but a big one can be palpable and is not palatable.
Okay, thank you, Professor Kakkar. Thank you, Dr. Kanduri, and all the dignitaries on the dais. I think I'm afraid that we have to break for tea. We'll be having a break of half an hour, and then we'll be back after half an hour for another case presentation, and that will be from medicine side. And in between, what we are trying to show you that those of you who have come late or who have reached the regional centers have missed some part of the presentations. What we'll do that during this break, we'll play the recording which we have done for your reference. And still, if you have got any questions, you can ask after the break. So with these few words, we'll break for tea, and then we'll be back at exactly after half an hour here.